The concept behind this trial was not that in the past 2 years there have been 3 publications, one from MD Anderson, one from the Germans, and one from the Italians, all showing very similar data, namely that patients who have a mutated IGHV gene have very long progression-free survival and a suggestion, very strong suggestion of a plateau on the PFS curve. So for example, if we look at the MD Anderson data, which has the longest follow-up of the 3 studies because FCR was developed at MD Anderson, what they showed is that if patients were mutated, the progression-free survival curve plateaued at 60% at 10 to 16 years. In other words, 16 years out, these people have no recurrence of disease. Are they cured? I think there's a good likelihood they are, and MD Anderson had some data in that paper also showing that, at least in the peripheral blood, when those patients came back for their long-term follow-up, they were MRD negative, again, suggesting the possibility of a cure. So although there are a lot of use of Ibrutinib now frontline, and it's a very effective drug, the thought was, well, do we really want to throw away chemotherapy in the mutated population if it's in fact producing a cure fraction? But what we would like to do is minimize the toxicities of chemotherapy, both the short-term and the late toxicity, which is a small percentage of people who get, for example, secondary MDS or AML. So we'd like to improve the outcomes, shorten the chemotherapy. How could that be done? Well, one change that was made to the FCR regimen in this trial was substituting Obinutuzumab in for rituximab, with the idea being that there's pretty good data that that appears to be a more effective antibody. The second change that was made was adding Ibrutinib in with the chemotherapy, because there certainly is data, for example, from the Helios trial, where BR plus Ibrutinib performed much better than BR alone. So the idea is let's add it to the chemo. And then the idea being, well, we've changed the antibody and we've added in Ibrutinib, maybe after 3 cycles, you don't need any more chemotherapy. And there is some built-in maintenance with both antibody and Ibrutinib, and then at 12 months they assess the MRD, and patients who are MRD negative actually can come off all therapy. And the comparison here was the historical control data for the MRD negativity rate at 3 months with FCR in the MD Anderson database. And that's roughly about 25%. And what they're showing here is that the MRD negativity rate after 3 cycles of FCO, if you will, plus Ibrutinib was upwards of 80%. So dramatically different than what was seen with 3 cycles of FCR in the historical control population. And some of these patients have now become MRD negative. And you also have the benefit, again, of a much shortened chemotherapy regimen of only 3 cycles. So I think this data looks really promising for that mutated population, where I don't think we're ready to give up chemotherapy, but would like to perhaps minimize the amount of chemotherapy.